So would love to hear your thoughts in between, my presentation as well. So if you have any questions in the meantime, please feel free to drop them in the chat, and I'll do my best to answer them to the best of my ability. So without further ado, let's just go ahead and get started. So just a disclaimer, the content of this presentation is just for educational purposes. There might be, it just represents my own knowledge and it's done to the best of my ability. So just to keep that out there. So our agenda, we'd be looking at Crohn's disease, ulcerative colitis, IBD complications, and then we'd look at a GI emergency, and we'll do some questions at the end. We'll also be looking at IBS a little bit, so just to keep that in mind. So we have a case here of a 22-year-old woman who presents to her GP with a 4-month history of crampy right iliac fossa pain, diarrhea 5 to 6 times per day, sometimes bloody, 6 kg weight loss, low-grade fever, and she has a sister with bowel problems, and she smokes 10 cigarettes a day. Her bloods show an elevated CRP, ESR, low hemoglobin, and low albumin. So what is your top differential? Just please feel free to put them in the chat. So are we thinking something inflammatory or infective? I know we just said that it would be something to do with Crohn's, but if you're thinking about any other differentials, what do you have in mind? And we've also mentioned right iliac fossa pain. So what are you thinking about? Anyone? Any thoughts? Ulcerative colitis? Yeah, IBD is certainly a possibility. So, it could be Crohn's or ulcerative colitis. Any other differentials? Appendicitis, yeah, that's a good one with RIF pain. Anything else that we're thinking with RIF pain? Also, how would we rule out appendicitis? What test would we do to rule out appendicitis? Like just a clinical exam. Any thoughts? I can go through some of the differentials I had in mind till then. So I was thinking, if I wasn't thinking of IBD, maybe the weight loss and the fever, would be a little concerning for maybe a colorectal carcinoma possible. Even gynecological malignancies, or, just gynecological issues that, people could have, like ectopic pregnancies as well, could be a possibility. Anything like diverticulitis could be a possibility as well, infective colitis. So there's a good number of things that you can think of when you're thinking of IBD. And you're probably most concerned about the fact that, she is having blood in her stool, as well as the fact that she's lost, a lot of weight. And also one more thing to, just mention when probably taking your history is to ask, was this intentional or was this unintentional? Because sometimes patients would just say that, oh, like it's probably because of my diet or, things like that. So just to keep in mind that, did they want to lose that weight or not? And also we probably would want to ask a bit more about travel history and things like that. So, did she travel anywhere recently? But yeah, good thoughts. And to rule out appendicitis, we would do the McBurney's test, and we would see if McBurney's sign is present. And in that case, and usually appendicitis is more acute, so IBD is a lot more chronic. So just keeping that in mind when you're kind of justifying your differentials even to your examiner. Perfect. So these are the red flags that I mentioned. So she's young, also has a bit of a family history with her sister, having bowel problems. So usually Crohn's especially has, genetic connotations. So just to keep that in mind. So how does Crohn's disease develop? So usually you would have genetically susceptible people. So they would have NOD2 variants. So the innate immune cells, they misread the normal gut bacteria as a threat. And this triggers a chronic Th1, Th17 response that is transmural. So with Crohn's, you would have the full bowel thickness that is affected. With ulcerative colitis, this is not necessarily the case. We'll go into that in more detail a bit later on. And you would have patchy inflammation with skip lesions, and it can occur anywhere from the gum to the bum, or mouth to anus, and it's usually found in the terminal ileum. So that's kind of why she's having right iliac fossa pain. So why do these symptoms happen? So in terms of transmural inflammation, you have full thickness damage leading to fistulas, abscesses, strictures, and the terminal ileum is where B12 and bile salts are absorbed. So the disease here, like B12 deficiency and bile salt malabsorption, you can have like diarrhea, steatorrhea, oxalate, kidney stones, and you could have chronic mucosal damage plus malabsorption. So that explains the weight loss and the low albumin. And you would have granulomatous patchy inflammation. So it would be cobblestone mucosa, normal looking areas in between. And another thing to keep in mind, the granulomas would be caseating in this case, whereas, for example, in TB, it's non-caseating. Perfect. So the key features, we've mentioned a lot of these already. So the transmural inflammation, skip lesions, cobblestone mucosa, it's non-caseating granulomas, I mixed that up. And it's most common in the terminal ileum, and you would have bile salt malabsorption. So if you compare Crohn's and ulcerative colitis, you would have skip lesions in Crohn's, whereas in ulcerative colitis, it's continuous. And, in terms of the layer, it's transmural, and over here, it's just mucosal. There is rectal sparing in Crohn's, so you wouldn't really have issues with your rectum as much. And compared to ulcerative colitis, you almost never have rectal sparing. And smoking is actually protective in ulcerative colitis, but it increases the risk in Crohn's. So what would you say to the examiner about why Crohn's rather than ulcerative colitis? You would talk about the RIF location, the weight loss, smoking, family history, bloody diarrhea, which is typical for Crohn's, and also mention that the biopsy would show transmural granulomas, and the smoking is supposed to sort of be protective for ulcerative colitis, so they're less likely to probably get ulcerative colitis with smoking. So that's one thing you could probably mention. And usually, like, Crohn's is more genetic, so that's another probable reason that you can mention. And you would have blood on your glove instead of bloody diarrhea with ulcerative colitis. So in terms of your management now, you would have, so when we're thinking about IBD, we'll think about IBS as well. So IBS is basically having the symptoms but not having anything that you can find on your examination or any sort of imaging that finds anything seen on there. So IBS is more of a functional disorder. You wouldn't actually find any positive results. You wouldn't have any inflammation or structural damage. So it's usually driven by a gut-brain axis, visceral hypersensitivity, and altered motility. It's usually triggered or worsened by stress, diet, or a prior GI infection. So it's defined by symptoms. So the pain is linked to defecation, bloating, and altered bowel habit. So why does it mimic IBD? They both have similar sort of symptoms, but IBS wouldn't really have the weight loss or the rectal bleeding that you would see with IBD. But at the same time, the kind of crampy, colicky sort of pain sometimes that you get with IBD is similar to what you would get with IBS. And you would have a change in your bowel habit, but you wouldn't have, the actual blood in your stool or, the weight loss that comes with it. And there would be no mucosal inflammation, or you wouldn't see anything on, for an OGD, or, things like you wouldn't see anything on imaging, a colonoscopy and etc. So you wouldn't see anything on there. So, in order to basically, rule out IBD and IBS, so you would start off with assessing the severity. So, you could use the Harvey Bradshaw scale. You would order bloods, the FBC, CRP, ESR, LFTs, albumin, B12, folate, and your stool calprotectin. That's the most important one to rule out IBS from IBD. And you would do your colonoscopy and biopsy for diagnosis. Once again, if you see anything on here, this would rule out IBS. And you could do an MRI enterography, so for the small bowel assessment. And if it's a mild flare, you would usually start off with oral steroids, so budesonide. If it's moderate or severe, you would give prednisolone and azithromycin. You would probably then give some biologics, infliximab, adalimumab, and in terms of surgeries, you would resect that area of the bowel if there's a stricture or a fistula. And sometimes, the patient would even have to go home with a stoma just because you've resected that part of the bowel. And, what you must not do if you're trying to distinguish between IBS and IBD is do not give reassurance just yet after one normal calprotectin. So you would have to repeat if there's still a clinical concerns. You would not give NSAIDs because this would actually trigger flares, and not dismiss symptoms as just being IBS in a young patient. Still just run all the tests to be on the safer side. And, also just ensure that you rule out any infective causes before you actually give medications, just because if it's something infectious, it can be treated much easier than, actually giving the medication for IBS or IBD, which is a bit more complex. So we always want to ensure that we probably even start with the WHO pain ladder, but just ensure not to give them NSAIDs because this can trigger flares, but look into other maybe pain medications if they're having severe pain, if they need it. So, that's another thing to look out for. Okay, so we're now going to move on to ulcerative colitis. And now we have a 35-year-old non-smoking man who presents with bloody diarrhea almost 8 to 10 times a day. He's having urgency and tenesmus. He's having left-sided abdominal pain, and this is on a 2-week history, and he has no recent travel. So no weight loss and systemically well. The PR exam, you find blood on the glove, bloods, he has mild anemia and a CRP of 45. So, a few things to sort of distinguish from the Crohn's, presentation is the fact that, there's no weight loss, he's systemically well, and, both of them did have bloody diarrhea, but you also have, the PR exam having, blood on the glove. So that was not necessarily seen with Crohn's. And, mild anemia, it could happen, but like it's more sort of common in ulcerative colitis. So if you had to think about other, differentials for this patient, what would you think about? Any ideas? Yeah, that's a good idea. That's and obviously Crohn's would also be on your differential list just because, it is still IBD, and, the symptoms do sort of overlap sometimes. If this was a female patient, you would still think about gynecological issues that she might have because you have, your ovaries on either side, so ovarian torsion is possible. So and usually with ulcerative colitis, it presents on the left side, whereas with Crohn's, it usually presents on the right side. So you'd have different sided pain. But just one thing to keep in mind about that. But apart from that, yeah, like those are, pretty good things to be thinking about. Diverticulitis still could apply over here. But yeah, so we'll move on then. So, what features point towards ulcerative colitis over Crohn's? We discussed some of them already. The fact that he's a non-smoker, it's, smoking is protective in ulcerative colitis. So the fact that he's a non-smoker kind of, shows that it might have developed. And he also has tenesmus and urgency, rectal involvement. That's a very important one to keep in mind. And bloody stools, left-sided predominance, no weight loss. So, in terms of the pathophysiology of ulcerative colitis, so it's sort of similar. It's an abnormal mucosal immune response, Th2 skewed, and it drives inflammation that stays confined to the mucosa and submucosa. So, it's never transmural. So, this is important because in Crohn's, it is transmural. And the disease is continuous, no skip lesions, and always starts in the rectum, spreading proximally up the colon. And you have crypt abscesses as well because the crypts fill up with neutrophils, and you would have superficial ulcers. So why do these symptoms happen? So the rectum is always involved. You have tenesmus, urgency, frequency. So these are all symptoms associated with the rectum, and you don't really see them as often in Crohn's disease. You would have crypt abscesses, superficial ulceration. So you'd have blood and mucus in the stool. And usually ulcerative colitis, you would have more blood in as compared to Crohn's. So anemia is more of a possibility here. So one thing to keep in mind. And it's mucosal only in terms of the inflammation. There's no transmural inflammation compared to Crohn's. And fistulae and abscesses are not as common in ulcerative colitis. You also have chronic inflammation, which destroys the haustral folds and leads to the lead pipe colon appearance on imaging. And severe inflammation impairs the colonic neuromuscular function. So the colon dilates, you would have toxic megacolon. This is a complication that you see with Crohn's as well. And long-standing extensive mucosal turnover, so there's an increased risk of colorectal carcinoma in ulcerative colitis as compared to Crohn's. So, in terms of the severity and management, you usually use a true love and wits criteria. So, you also have another category called fulminant. It's more than 10 times the frequency would be more than 10 times per day. But usually you would just stick to like mild, moderate, and severe. But, just have a read over the scale to kind of get an idea of, in your own time, just to sort of get an idea of each criterion. You don't need to obviously know it by heart, but just a basis, like you see that they're more systemically unwell here. So just sort of knowing that, and like the increased frequency of stool, things like that, just to note down and mention as like brownie points, in your OSCE. So in terms of your management ladder, you would start off with, your salicylates. So mesasalazine is the most commonly given that I know of as well. So you could have it oral or topical. And in terms of your moderate, you would add oral corticosteroids. Severe, you would add IV hydrocorticosterone and cyclosporin and consider surgery. So in terms of your maintenance, you would have azithromycin or a 5-ASA long term, which is a 5-ASA is just an amino salicylate. So in terms of your surveillance colonoscopy, you would basically pancolitis, it would be 8 years, and then every 1 to 3 years, because there's a risk of colorectal cancer. And the risk increases with the extent, the duration, severity, surgical, cure. So it depends on the surgery that they do and, the occurrence and everything else. So a patient with severe ulcerative colitis fails IV steroids after 72 hours. What do you do next? Any thoughts? Yeah, like they're not really responsive to it. Yeah, yeah, that's So you would add in IV cyclosporin, or you would do a surgical review. So you would see if there is a need to actually do a colectomy. But you would try out with cyclosporin first and then see if it's needed. So usually, steroids can like fail after 72 hours. Patients can become steroid refractory. So they're unlikely to respond to more steroids. So it is helpful to maybe consider surgery then, because it is quite curative. So that was a good answer. Now, in terms of complications, what are you thinking of? So if you think about intestinal complications versus extraintestinal complications of IBD, any ideas, any thoughts just before, I display the answers? I've mentioned some of them already. Yeah, exactly. Any other complications? Think of, extraintestinal complications as well. Yeah, yeah. Because if you think about it, it's kind of like an autoimmune disease. So a lot of the times it does, manifest elsewhere as well. So yeah, toxic megacolon, colorectal cancer, any strictures, abscesses, fistulae, hemorrhage. So I've just divided the extraintestinal in terms of, the different body systems. So in terms of the eyes, you can have uveitis, episcleritis, erythema, pyoderma gangrenosum, arthropathy, ankylosing spondylitis, primary sclerosing cholangitis, oxalate stones, osteoporosis. So yeah, so moving on to the GI emergency. So you have an emergency case. The same ulcerative colitis patient presents 3 years later to the emergency department, and they're having 15 bloody stools per day, rectal bleeding. They're distended, tender abdomen. The heart rate is 115. Temperature is 38.5 degrees. BP is 90 over 60. They're hypotensive. They have a dilated transverse colon, 8 centimeters. Their lactate is 3.2. So, what is your top differential? Yeah. And so, in terms of your immediate management, you would resuscitate them, give them IV fluids, you would give them O2, and then IV corticosterone, hydrocortisone, urgent surgical review because you want to see if you need to give them a colectomy, bloods, so your FBC, CRP, LFTs, lactate, and just check, their just check if they're, fine, and stop any anti-diarrheal agents. So why are we stopping any anti-diarrheals? Any ideas? Okay, so basically they can precipitate toxic megacolon by reducing the colonic motility. So, it's just important to flag that you would you would never really like give them you would never stop you would stop the antidiarrheal agents, and you wouldn't give them any antidiarrheal agents. So then you would also check the colon size, and if there's no response, in 72 hours, you would give them cyclosporin or a colectomy. That was something we discussed already. This is something you can keep in mind, just to sort of mention and get brownie points when you're doing your OSCE. So just mention the Jalen criteria. So that's mostly it. I'll hand it over to Hamza then.
Thank you so much, Rhea. It was such an informative session. And before heading towards high yield SBAs, I will give you a very brief demo of how the MLBD is working and how thousands of medics are using it daily to practice for their OSCEs and also using flashcards and other things, right? So I will take like 3 to 4 minutes of you. Let me quickly share my screen. Just give me a second. Okay, so okay, let me share the screen again with the audio so that you know how it's working. Okay, so here we go. Okay, so I will attempt one of the cases. I'd rather not to talk about it. You're FI1 in gum clinic. A 19-year-old woman named Sarah presents with yellow vaginal discharge and occasional pelvic discomfort, right? So here's a walkthrough as well. If you really wanted to have a quick walkthrough before attempting the case, but would recommend straight going to the station so that it would test. Okay, so setting up the time. Let's start the station. Hello, my name is Dr. Hamza. I'm one of the FY1 doctors here in the clinic. Could you confirm your full name and date of birth for me?
Hi, my name's Sarah Thompson. I was born on May 12th, 2004.
Okay, thank you, Sarah. Before we start, I just want to say everything we talk about here is completely confidential. This is a safe space and there is no judgment at all. And nothing leaves this room unless I'm ever worried about your safety. Is that okay if we spend the next little while talking through what's been going on? And I'll ask you some questions as we go.
Yeah, okay. I mean, thank you for saying that. It's just, I'm a bit nervous, but I guess it's okay to talk. I'll try my best to explain what's been happening.
Great. So, in your own words, and no rush at all, what's brought you in today?
Well, it's just that I've been noticing this yellow discharge for like the past few weeks. It's been kind of worrying me because it's not really like normal for me. And sometimes I have this pelvic discomfort too, but I'm not sure if it's, I don't know, serious or not. It's just been making me feel really weird and a bit uncomfortable.
Okay, so thank you for telling me that. I know it's not easiest thing to bring up, and you have done the right thing coming in. So could you please, sorry, I forgot. Could you please confirm the color of the discharge?
Yeah, sure. The discharge is kind of yellowish. It's not bright yellow or anything, more like a pale yellow, I guess. It's definitely different from what I usually have, which is more clear or white.
Okay, that's really helpful, and thank you. And you mentioned some discomfort low in your tummy. Can you describe that for me? Like where exactly and what does it feel like?
Yeah, it's like right in the lower belly, just kind of around, just under the belly button a bit. It's not sharp pain or anything, more like a dull ache or sometimes like a heaviness. It comes and goes, but when it's there, it makes me feel kind of uneasy, I guess. I'm not sure if that makes sense.
Okay, guys, so you could complete the entire case. I'm going to done talking and end the station. So this is a very brief demo of like how the platform is working and like how thousands of medics are using the platform daily to practice, right, for their OSCEs and obviously ongoing learning. For those of you OSCEs are over, obviously, congratulations to them. So what we're going to do is it's going to analyze my performance. It will take my, the entire transcription, my biomarkers, and it will tell me like what I did wrong, right? So also I did very pretty average borderline, but I've seen like most of the people did pretty overline for this station because we are in top 50. It's a difficult station, I'd say. So it will give examiner verdict. So you demonstrated strong communication skill and created a safe space. But you missed several key points, obviously, in history. So as you go, you have to, complete the entire case. So this is exactly like what to focus on. Next, did not assess red flags, missed key elements of focus history, and did not take medicine. And you have to complete the case, right? Complete the entire station. So this is a very granular level data of how you could perform perform better for the next time, right? So right at the end of this thing, like how can I perform, how can I improve my assessment for red flag, especially reading fever and partner symptoms in future stations? This is very important. I've seen like most of the people, most of the users on the platform are using this thing to improve their consultations, right? So so to improve your assessment of red flags in future stations, fever and chills, always ask directly if the patient has experienced any fever or chills, right? For example, have you had any fevers or chills recently? This help rule out, serious infections like pelvic inflammatory disease, kind of like that, right? So, so this is from the station attempt. Let's give, let's go with the good station thing, realistic scenario, submit this thing. Even though I should have because I didn't perform well, but let's press to the main bit. So you can obviously for the gastro part, which we have, we have category 4, you can attempt the cases for gastro. There's another so most of the people at the moment are creating their own cases, like for the part history taking. So let's go with gastro. Like okay, so if you're unsure about the topic, continue with that. So here you have to select the guidelines, and it's a very super important step. We are selecting GMC guidelines or NHS guidelines. Then go with FY1, and we're going with generating the case, right? So what it's going to do is it's going to generate 3 briefs for us so that we could select that thing from. If you have your if you have your own notes, or your university have given you some kind of like an guidelines or checklist, you can simply put that thing into the platform, and it will generate that for you as well. So we are selecting this. We are not going to attempt the case. We are just going to generate that thing. So what we're going to do is it's going to check the scenario. It will test it will build the walkthrough. So walkthrough is important because there are times we have seen like most of the people, most of the users, medics are not pretty unsure about how to attempt the case, right? But we don't really make that thing scripted, because if we're going with before starting the station, if we are going through the walkthrough, that sometimes like it's kind of like a you would know what to expect, right, for the case. But in exams or OSCE exams, you won't really know what to expect exactly when entering into the station, right? So the most important part is the marking rubric. So it has generated the marking rubric for you. You can add any criteria if you want, but I think it's enough if you could go with this. There are critical fields as well. So did not ask any red flag questions. So for this station, 35-year-old with abdominal pain and diarrhea is important. So this is what your your door instructions are. And let's only save and attempt the case, right? We are not going to attempt the station or anything. So another thing that people are, or medics are mostly using, is flashcards. So apart from Anki, and they are also importing their Anki things as here. So you can create your own. We are not going to create for now. You can create for any topics, or you could go with your upload any files. Like for this case, for Rhea's gastro case, we are going to upload the the PPT here, and it could generate the flashcards for us, and people are sharing with their friends as well, or you could paste your notes as well. So one of the feature, I'd say, which is the users are using pretty crazy, as this the ward feature. So this is a gamified version of the ECG or ABG for now, and we are adding more games here. So let's go with, so I'll need support from you guys, especially if Rhea or anyone could you could tell me the answers for this. We are not sure about the answer. Let's go inside the ward. So it's basically an ABG ward, right? So here we go. This is our this is the doctor. We are going. Let's go with this. Rhea, could you please help me in this?
Yeah,
Okay,
sure.
so okay, I'll press E, and I'm not exactly sure what the answer is. So it's this is, I think, let's go with, I don't know. Okay, so it's okay. So let's go with the patient, this patient, and we'll go with, okay, so we're not good there as well. You have to read that thing because the timer is running, right? So, okay, so we are going to, attempt that thing just so that we know how this thing is working. Okay, so yeah, we have performed pretty bad in this. So 5 patient misread, flagged for review. So it's gonna, it's kind of like an algorithm that will show you more cases which you are weak in, and we are
Can we
adding
change the
hard.
timer on this? Can we give
Sorry,
ourselves more time at the start? Can we change the amount of time that we're given?
not exactly at the moment because I know like the ADG reading is hard. But we could add we on in a roadmap, we could add that thing, right? So back to the menu, you could go with the ECG thing as well. It's quite, there are modes to ECG as well, right? So let's go with the foundation one. So, okay, let's attempt this. I think it's, I don't know. Let's go with sinus rhythm. This patient is, oh, okay. So I think it's atrial fibrillation. Okay, so it's also the atrial fibrillation. So, okay. So lastly, I think it's complete. I don't know. Okay. So this is how exactly it will evolve to. So the areas which you are weak in, it will show you more ECG kind of like rhythms in that. We are adding more games to it, and it will be completely free for everyone to use. Right? Thank you so much. Also, there's a discount coupon as well for everyone. I'll be dropping that thing in the chat. So we are moving to the SPAs. Thank you so much, Rhea. Over to you.
Yeah, absolutely. That was actually really cool. I might use that myself. So just moving on to the SBAs. So this is just an exam code. If you want to use that, you'll have access to these slides. So okay, I don't know why it's showing up like this, but let me see if I can. I'm just gonna. Okay. Yeah. So a 28-year-old woman with known Crohn's disease presents with a new perianal fistula. She is currently in remission on azathioprine. Which of the following is the most appropriate next step? A. Start oral prednisolone. B. Add infliximab. C. Increase the azathioprine dose. D. Perform a colonoscopy. Or E. Refer for emergency colectomy. What do you guys think? And honestly, don't worry if you get it wrong, or don't worry about just getting it wrong. Feel free to just attempt the question, because I know this was a really quick session, and like it's a lot to kind of get through in less than an hour, so it's completely fine if you get it wrong. Any thoughts, anyone? Yeah, that's correct. Okay, so we'll move on to the next one. So basically, do you have any reasoning for why it would be infliximab? Just to sort of get this out there. That's fine. So basically, we would give infliximab because it's a biologic, and usually it has its own, Crohn's has its own treatment pathway, separate from luminal disease activity. So we wouldn't give something like, we wouldn't. She's already on a theoprene, so I don't think there's any point in increasing the dose. Prednisolone, it wouldn't really help with the fistula. Infliximab, it actually does, it has proven, efficiency or efficacy against fistula. So this is something that you would use as first line. And actually, if you look at, the treatment and things like that, you would notice that, infliximab is one of them that you would give. So yeah, you would give infliximab. And yeah, you wouldn't really perform like a colonoscopy because it's not too, relevant to Crohn's. And for an emergency colectomy, that's a little too soon, like in the sense you would still want to see if she's responding to medical treatment before considering, surgical review. So infliximab would be the right option because of this. So moving on, you have a 42-year-old man with a 15-year history of extensive ulcerative colitis, and he attends for a routine review. He is currently in remission. What is the most appropriate surveillance recommendation? We discussed this today, so just probably try and have a guess. Yeah, exactly. So that's basically what the guidelines mention. So you would have a colonoscopy at 8 years and then 1 to 2 yearly, depending on the risk. So now you have a patient with ulcerative colitis who is admitted with a flare. So after 72 hours of IV hydrocortisone, they continue to have bloody stools per day. CRP remains 120. Which two options are the appropriate next steps? We discussed this as well. So actually, you can choose two answers. Don't ignore the select best single answer. Yes, correct, exactly. So you have a 24-year-old woman who presents to her GP with a 6-month history of intermittent abdominal pain and loose stools. She reports bloating and symptoms worsening during exam periods. She denies any rectal bleeding, weight loss, nocturnal symptoms, or fever. Examination is unremarkable and blood tests are normal. Choose a single best answer. So now, what are you thinking? Are we thinking IBD? Are we thinking what's your differential when you look at this patient? What is something that you could use to distinguish? Yes, exactly. So we're thinking of IBS. So what is something that you could use to distinguish IBS from IBD? So it wouldn't be a colonoscopy, but I mean, you would do a colonoscopy just to rule out, the chances of IBD. But if we're thinking specific to IBS and IBD, what would we be looking at? Yes, B. So the stool calprotectin, that's the most important that's the gold standard to rule out IBS from IBD. Perfect. So just to, reiterate, if you have a patient who is, young and things like that, you would still run all the tests, just to rule out if that person has IBD or not, because a lot of the times it can be genetic, especially with Crohn's. So you would want to rule out the fact that, they actually do have IBS and not IBD, because the treatment styles do vary and you want to treat this patient to the best of your ability. Oh. Okay, it's showing the answer already, but we'll go through it anyway. So we have a 29-year-old man with known Crohn's disease, and he presents with worsening abdominal pain, abdominal distension, vomiting, and constipation. Examination shows a distended abdomen with high-pitched bowel sounds. CT demonstrates the narrowing of the terminal ileum with proximal bowel dilatation. So over here, we're thinking that it would be post-inflammatory fibrosis causing stricture formation. And basically, it's when you think about the fact that he has, the high-pitched bowel sounds and things like that, we're thinking of some sort of an obstruction. And if you're thinking about small bowel versus large bowel usually you wouldn't hear any sounds at all. You would have, with small bowel, you would usually have, the tinkling high-pitched bowel sounds. So, we're thinking of something that could have cause a stricture just to, you know, lead to that obstruction. So that's why we would choose answer choice B. But yeah, that's it. Thank you so much for joining in today, guys. Please do, you know, let me know if you have any feedback for the session. We would love to listen to your thoughts and see if we can do something to improve our future sessions. And if you also want access to the PowerPoint, please do complete, scan the QR code just to complete the feedback to get access to the PowerPoint. Thank you so much for joining in today.